The next one is long-term clinical outcome of osteal LAD disease. Dr. Sandeep Singh. Sandeep.
Good moment for me to give this talk in front of my two mentors who have trained me also. So my topic is long-term clinical outcome of osteal LAD treatment. I was specifically asked to look into the data for osteal stenting versus left main crossover stenting. Why this topic of osteal LAD is important? First of all, osteal LAD, it supplies it's an important target area because it supplies the largest area of the myocardium. And we clearly know that in the earlier era, when there were balloon angioplasty, they were unsuitable for intervention because of significant risk of procedural involvement of left main or the left circumflex coronary artery. With the bare metal stent, there were a significantly higher restenosis rate to the tune of 25 to 40%. Drug-eluting stent definitely revolutionized the treatment for the osteal LAD. The target lesion revascularization rates were significantly lower. However, if we purely talk from a data point of view, the osteal LAD lesions in the earlier trials were excluded from most of the trials which focus on the drug-eluting stent. But presently, we are increasingly and frequently using drug-eluting stent for the osteal LAD intervention, and there is enough clinical experience for all of us. Unfortunately, the long-term outcomes have not been adequately evaluated in randomized trials. So whatever data we have only in terms of registries and the retrospective data. Now, why osteal LAD is very important? Because it's a complex coronary intervention. So there are four reasons. Either you do osteal stenting, or even if you pull it back and do it from left main to LAD stenting, crossover stenting. One, in a osteal stenting, there can be a geographical miss. You can miss the lesion at the ostium, and that could play a role in the long-term outcomes of a particular patient. Secondly, if you try to position your stent into the left main, then there are few struts which may come into the left main. They may come in front of the circumflex. What are the consequences of that? I will highlight in my subsequent part of my slides. And thirdly, if we do a crossover stenting, the issues of size discrepancy between the left main and LAD, which was very important in the earlier era, and a fear of a side branch jailing. So first, I'll try to discuss what are the long-term results in terms of overall the osteal LAD as we compare it with the proximal LAD. So there is a registry data by the Japanese Cipher registry, and you can see that in this is a long series of around 5,800 patients, which divided the patients into predominantly into the proximal LAD and into the osteal LAD, and then in the further osteal LAD were further categorized into those who required a osteal stenting and those who required a crossover stenting. So if you can see that the target lesion revascularization and a death or myocardial infarction did not differ between a proximal LAD procedure and an osteal LAD. That gave enough confidence as compared to what was happening with the earlier era of bare metal stent to proceed with doing the osteal LAD procedures. Similar to the J-Cipher data, there was an Italian data which has a 2-year outcome. You can see that all the parameters which prognosticate a particular patient as far as the long term is concerned, be it cardiac death, all-cause death, target lesion revascularization, these all were in a single-digit number. So that gave us sufficient confidence to proceed with the interventional procedures for a osteal LAD disease. Now, another important point which we need to discuss is, once a patient is being taken up for a stenting, shall we do a osteal stenting or we do a left main to LAD crossover stenting? Unfortunately, there is no randomized data. There is only retrospective observational studies, and we have to bear with that. If you can see that there are 5 such studies which have noticed a comparison between osteal stenting and the crossover stenting. In fact, 2 of these, the Kishi et al. And the Carapenzo et al. Use the first generation drug-eluting stent as compared to the remaining which used a second or a third generation drug-eluting stent. Now, in the comparison between the osteal LAD and a left main to LAD crossover stenting, you can see that both were consistent in their results. There was some increase in mortality in the left main to LAD crossover, though it was not statistically significant. Does this generate a hypothesis? It was because of earlier the stents were not that expansile in nature? We really do not know, and it's too late to dig into that because these stents are no more available in the market. But more importantly, for the second and the third generation diluting stent, you can see that there is a statistically significant difference as far as the target vessel revascularization is concerned. Now, this data is from recent, and it consists of contemporary practice of using rotablation, and more than 50% of the patients underwent intravascular ultrasound also. And you can see clearly that the target vessel revascularization was statistically better with a left main to LAD stenting as compared to ostial LAD. And in fact, on the follow-up angiogram, predominantly the restenosis occurred at the ostium or at the distal part of the left main. Perhaps it could be because of a geographical miss or because of the injury to because of the balloon to the distal part of the left main. So what have we learned as of now? What we have learned is that when we compare ostial stenting and the crossover stenting, the target lesion or target vessel revascularization rates tended to be higher in the ostial as compared to a crossover strategy. In some series, it was statistically significant, but in almost all, there was the trend towards a higher incidence with the ostial stenting. However, the safety was similar in both the cases. The use of imaging IVUS and OCT was significantly higher when we use the left main to LAD crossover strategy, and the procedural complications were not different. Now, this takes me to the last part of my talk, that what are the factors which can influence the long-term outcomes in a patient who is undergoing ostial LAD procedure, be it a ostial LAD precise placement of a stent, or be it the left main to LAD procedure. So the first question I would like to pose is, and then I'd like to answer after a few of the data which I will mention, is, do we need to perform intravascular imaging in such cases? Now, why this is important? Because if you see, a landmark study focused on angiographic classification of the distal left main, in which ostial LAD was involved, along with IVUS, which was done in these patients to further classify these distal left main or ostial LAD disease. You can see that barely only 3% of the lesions are actually ostial LAD. In more than 90% of the lesions, there is a continuous involvement from the distal left main which goes into the proximal LAD. And this is very important because once you use a strategy, you may injure this particular area of the vessel and cause a higher incidence of long-term complications in these particular patients. No, there are a few cartoons. See, these two images, they look exactly similar. The inner part of the vessel look exactly similar once you see it from an angiographic point of view, but from real anatomy point of view, from imaging point of view, these two are totally different. In the first case, this is the green square mentions the exact placement of the stent, which was correct decision, while in the second case, there was a distal left main plaque, which perhaps could have been injured or could get injured and cause long-term not favorable outcomes in these particular type of patients. Above that, there is definitely a role of imaging, because it can definitely tell us right at the beginning any major discrepancy in the size of the left main and the LAD, whether you can go from a crossover stenting from left main to LAD or not, or precise ostial stenting will be a better option in a particular patient. Now, second question which comes is that what do we do for the side branch circumflex? Be it ostial stenting, where few of the struts are floating into the circumflex, or be it a left main to LAD crossing. There is no randomized data, there is no major publications in that, but predominantly in majority of the time you have to keep it simple by keeping a simple strategy of left main to LAD stenting. And in majority of the cases, as you can see in the subsequent slide, that in 73% of the cases, especially in the ostial LAD, there is no pinching or no involvement of the circumflex artery. In 17% of the cases, there may be some involvement, while intervention is required only in 3 to 5% of the cases. So in predominantly cases, you have to keep it as simple as possible. In fact, the angiographic involvement of left circumflex artery and the functional involvement of the left circumflex artery, they don't go hand in hand, as you can see over here. And it's only those who have a long-term bad prognosis from a circumflex ostium was those who had a poor FFR from functional assessment of these particular lesions. Third question is, do we need to do port in every case in the crossover stenting? The answer here is very simple, and I will not spend time. The data is extrapolated from the left main stenting, that yes, every case, especially when you are doing a single stent strategy from left main to LED, the port has to be done because it has consistently been shown to improve the prognosis as far as the long term is concerned. And my last is that you have to choose the stent properly. There are some stents which can be stretched or expanded up to a particular sizes. There are larger sizes of the same stent available. So in that way, imaging becomes very important as far as when you are doing a ostial LED procedure, be it stenting from the ostium or from left main to LED. So to summarize, there are no large-scale studies, no randomized trials. If we really go into the research part of it in terms of ostial LED intervention, but there are definitely retrospective analysis. Optimal approach for most of the ostial lesions requires intravascular imaging, there is no doubt. Crossover stenting, yes, very likely. Choose appropriate stent design which can be expanded, yes, undoubtedly. And port, especially in a case with the left main to LED where there is a significant size mismatch, undoubtedly it has to be done. But still, you can have to individualize because there can be cases in which the visualization of the circumflex is very clear, the left main is absolutely free of disease, and there is a significant mismatch between the size of left main and LED. The case is well set for ostial stenting. With that, I'll end my talk. Thank you for your kind attention.
Sir, nice presentation. Sir, in your routine practice, how do you approach ostial LED lesion? Do you do imaging for everyone? Question number one. Secondly, in absence of imaging, would you always go for a crossover stenting?
There is no hard and fast rule. With experience, we really come to know whether, see, the ostium is a 3 millimeter area. So, where is the maximal plaque distributed? If it's a very tight flush ostium, I would definitely like to go from left main to LED if there is no major discrepancy in the size between left main and LED. But if there is some area of scope and imaging is not there and we are 100% sure that there is no distal left main involvement, circumflex is clean, one may think of going with a ostial LED stenting with the second or third generation stent, as I mentioned.
Slightest of doubt, you would do crossover.
Yes, definitely. Yes, it is there are no randomized trials, but yes, a preference has been given nowadays to left main to LED stenting as compared to ostial stenting for flush LED ostial disease.
Sandeep, one very burning issue which often is addressed to us who do a lot of left main stenting. See, the European Bifurcation Club believes that if there is a left main disease and extending onto LED and they are doing a provisional stenting of the side branch, that means stent from left main to LED. They electively do a kissing balloon dilatation at the end of putting in a stent from left main to LED. So in a situation like this, what you're saying, if you have to do a backward stenting from LED to left main, is there any literature and what are your views whether we should end up by doing a kissing balloon or whether we should leave the struts as it is from left main to LED stent?
Sir, if it is a true bifurcation disease, definitely.
No, I'm not talking true bifurcation.
So if there is an ostial LED disease, it's always advisable that if such ostium is clearly visible and is free of disease, to keep it as simple as left main to LED without even touching the struts of the side branch, because it unnecessarily, in the long term, results are not changing because of that. But while doing this procedure, if there is a hemodynamic changes or there is angina or there is a significant pinching of the circumflex, which angiographically looks dangerous imminently, at that time I think you have to go into a bifurcation strategy. But otherwise, for majority of the ostial LED lesions, simple ostial stenting or left main to LED stenting should suffice.
Well, I think there are two ways in which this issue needs to be addressed. There was a study about 6-7 years ago on JACC where they randomized patients of left main to LED stenting and in one group they did a kissing balloon and in another they did not, and followed them up clinically for 1 year and there was no difference in MACE. Yes. So their conclusion was that we need not unnecessarily disturb the main stent from left main to LED unless there is an indication. Now the second thing is, when you see a pinching of the LCX ostium, in fact, of course, Korean people have shown that this pinching is not of any hemodynamic significance, and they have done FFR in majority of these patients, and their FFR was normal. And now the concept is flowing that this pinching is less often. Only 30% of the cases there is a plaque shift. 60-70% of the cases there is a carina shift.
Correct.
So you don't have to really worry too much on this. Just do a kissing balloon and you will be all right.
That's right.
When would you consider proximal LAD lesion as a non-osteal versus osteal? Means how much landing zone is necessary to differentiate between very proximal lesion versus osteal lesion?
It's easier for a proximal lesion, there is no problem. I mean, you can easily place the stent even if you have to place it from the ostium. So what I am talking is the true osteal, where it is within 1 to 2 millimeters. Definition says 3 millimeter. In that case, actually the whole talk was. But in the proximal LAD, the decision is very easy. Unless you show by imaging that there is a continuum of plaque burden starting from the distal left main extending into the early proximal part of the LAD.
So just one more. So you clearly showed that in cases where, like in the diagram also you showed that there is no actually true left main disease. Only 3% of patient had a true left main disease when we were doing imaging. So don't you think like every left main, either osteal, imaging should be a part of it?